So I presented a trial which was named Pivotal Trial, and the trial design is very simple. It was a one-to-one randomization towards the neoadjuvant intralesional use of daromun. I will explain the drug in a moment, compared to immediate surgery alone for patients with skin metastases and lymph node metastases. So it was a neoadjuvant trial, and patients were allowed to have prior treatment as well as an adjuvant treatment after the surgery was performed. Daromun is a new agent which has been published only the phase 2 data and in vitro data. And this agent has two components. One component is directed against fibronectin, which is found in tumor vascularization, and is directing interleukin-2 tumor-infiltrating lymphocytes into the tumor in influx. The second component is tumor necrosis factor alpha, which is inducing tumor necrosis. In mice, the mice tumors have only been killed if both components have been used together. That's the reason why this is a fusion product, I need to say, which is given intralesionally. It was done 4 times in 4 weeks, so 1 time per week. And the patient's endpoint was relapse-free survival, and this was positive, fortunately. The hazard ratio was 0.59, 41% risk of reduction in the risk of recurrence as well as the risk to die. And the secondary endpoint, distant metastasis-free survival, was also being positive. 0.6 is a hazard ratio, 40% reduction in the risk of development of distant metastases. So very good result, also pointing out that there is a systemic benefit for the patients. It's not only a local benefit. And the good thing about it is that there was almost no systemic toxicity. It's all local toxicity. If we inject, we cause inflammation. Patients may have pain, they have redness of the injected lesions, and sometimes they have also inflamed tumors, which can induce systemic reactions like fever. And this was well manageable, and there was only very few patients not receiving the full package of 4 scheduled injections. And we have no overall survival data. It's completely immature at this point of time after 2 years of observation period. But we are very happy, and now the company is submitting the data to the European medical agencies and hoping for a positive response. As an alternative for patients who might have a fear for serious toxicities with a combined immune checkpoint inhibition, or patients who have received already ipilimumab, nivolumab, because the mode of action is completely different. So the advantage is that we can inject intralesionally and causing no toxicity. And the data with relapse-free survival and distant metastasis-free survival are good, very clinically meaningful, and therefore it's something different.